Nalini and I'm the founder of Arogya World. We are a nonprofit that does global health work. We are focused on chronic disease prevention, non-communicable disease prevention, particularly diabetes prevention in India. We do large scalable programs that are targeting population level prevention, and we have made some good strides. Please look us up on arogyaworld.org. During COVID times, we have done a series of webinars, and this is the third in the series that we have initiated in in the last 6 weeks or so, focused on unpacking some of the issues around NCDs and social and societal issues that we care deeply about. All of us on this call are global citizens, and we are concerned global citizens, and we want to understand these issues by bringing you speakers and experts. So we had the first session was on mental health as a fallout from COVID-19. The last one was a chef who taught us a very interesting healthy recipe. And now we are focused on COVID and diabetes and to understand the race ramifications and other health inequity issues surrounding that. This is a very important public health talk at a very important time in our country and in the world. So without taking up more time, I want to introduce Swati Chaudhary. She's a board member of Arogya World in the US, who will engage in a dialogue with Dr. Venkat Narayan from Emory University. Swati, over to you.
Thank you, Nalini. Hi, everybody. My name is Swati Chaudhary, and I'll guide us through the discussion today. I would love for you to be an active part of the discussion. If you'd like to, there is a chat option on the right-hand side of your Zoom window. Please add your questions there. Don't be shy. I will be looking out for them, and we'll have the opportunity to address many of them. Folks, I have the privilege of being on the board of Arogya World. I also work in international development across Asia, Sub-Saharan Africa, and here in America. I'm from India, raised partly in the Philippines, and I'm also from the US. In the US, I'm an immigrant, a person of color. Heart disease and diabetes are prevalent in my family, in my countries, and now COVID-19 has ravaged through my communities. So I have personal stake in connecting these dots. And to help me do that, I have the privilege of hosting this conversation today with esteemed Dr. Venkat Narayan. Dr. Venkat is the Ruth and OC Hubert Chair of Global Health, Director at Emory Global Diabetes Research Center, and Professor of Medicine and Epidemiology at Emory University. He has been the Chief of the Diabetes Science Branch at the US Centers for Disease Control and Prevention, CDC. He's noted for substantial multidisciplinary work in diabetes and non-communicable diseases and public health, and he's a member of the US National Academy of Medicine. Thank you, Dr. Venkat, for joining us today. It's a privilege to have you with us today. And how are you doing?
Thank you, Swati. It's a pleasure being here. And I want to thank both you and Nalini. I've known Nalini for a long time and have a lot of appreciation for Arogya World, which has been a labor of love for Nalini. It's amazing with how much passion she's made that organization grow and have its impact. And it's been a pleasure getting to know you, Swati. I've known you for about a few days, and I know that you're going to pose extremely incisive and astute questions to me. So I am mentally prepared for all that.
Yeah, so let's dive right into this, Dr. Venkat. There's a burning question in my mind, and I know on the minds of many of our audience. What's the connection between diabetes and heart disease with COVID-19? What's physically different about a person with diabetes that puts them at higher risk of COVID?
Okay, so let me start with making some broad comments. Firstly, about the COVID-19 virus itself. I mean, this is a very new virus. It's an RNA virus of the coronavirus family, something which started initially in Wuhan, China, and has now become a global pandemic. It's something that's affected the whole world. I mean, more than 100 countries are already affected, by the virus. The virus itself, what we know about it, and there's lots of things that we don't know about the virus, but what we know about it is that it is highly infectious. The infectivity of a virus is measured by what's called R0. I mean, that's the reproduction rate how many people get infected by one infected person. That's the whole idea. So the virus seems to have an R naught of anywhere from 3.0 to maybe up to 5, which makes it an extremely transmissible and infective virus. Virus spreads very rapidly, largely through droplet infection, such as by sneezing, coughing, loud laughter, and in close circumstances, in close to physical circumstances, etc. It also spreads somewhat through aerosol infection, so that's also been suggested. But importantly, there is also possibility of transmission through fomites, such as surfaces that are commonly used and can last in surfaces for up to 3 days, and in metal objects can last for up to 8 or 9 days. So all of this makes the virus extremely transmissible, and that's why there is a big urge for hand hygiene, avoiding of touching of the eyes, nose, mouth, wearing of masks, social and physical distancing, and also cleaning of surfaces and being extremely careful. So that's the information we have about the virus. And then when you look at the type of people who are vulnerable to the virus and its complications particularly, these are people who are older, people with other comorbid conditions such as diabetes, heart disease, chronic pulmonary disease, cancers, etc. So anybody with these conditions are very vulnerable, and that's where diabetes becomes extremely important. So it's the interaction between the virus and the host factors such as diabetes and obesity and hypertension that becomes extremely important. Exactly what is it about people with diabetes that makes them vulnerable is a big question. From the data we have, there is no evidence that people with diabetes are particularly any more susceptible to contracting the infection from COVID. But we do know that people with diabetes are vulnerable to many infections and their complications. That's something that we clearly know. But however, once somebody with diabetes contracts the infection, the likelihood of them developing a complication such as hospitalization, needing to go to ICU, or even mortality appears to be high. However, I should note that the majority of the infections with the virus appears to be asymptomatic or mild, but those that contract it, and in this case, people with diabetes seem to be more likely to develop certain complications, all the complications of the virus. Exactly why that is the case is an important question that is being researched, but there are some clues. Clearly, anybody with high glucose levels seems to be at higher risk for the complications from the virus, such as hospitalization, ICU, and mortality. Even people without diabetes with high glucose levels seem to experience a certain higher risk. Is it something about glucose, or is glucose representing a general inflammatory state, or are there other factors? Is something that needs to be studied. And I have colleagues who are trying to examine the host gene virus interaction and the genetics of the virus more carefully. But more importantly, people with diabetes have other comorbid conditions. People with diabetes have their hearts affected, their kidneys affected, their lungs affected, their muscles affected, etc., because of the disease. So whether that makes them more susceptible to complications and to poorer outcomes is also an important question. And thirdly, of course, people with diabetes are on multiple drugs, whether there are potential interactions between the drugs that they are on and the disease, or on the treatment for the disease, such as COVID. These are all questions that are wide open. But the bottom line here is, currently, we don't have any evidence that people with diabetes per se are at increased risk of contracting the virus. But we have strong data to suggest that once people with diabetes contract the virus, they are at higher likelihood of complications, such as hospitalization, ICU, and even death. Thank you. You're muted, Swati.
Yes, that is so interesting because diabetes is a non-communicable disease, and COVID-19, the virus, leads to a communicable disease. And the two are interacting both in the form of heightened risk of not necessarily contracting, but of getting more severe forms of the illness and hospitalization, and also interacting in terms of the medication. Dr. Venkat, there's another burning question I have, especially in light of the social justice movement that is gaining ground in America and across the world. Are there particular demographic groups that are at higher risk or have been disproportionately affected by COVID-19 by age, race or ethnicity, geography, income class, otherwise? And what puts these groups at higher risk?
Okay, and firstly, I mean, I like the distinction you made between COVID being a communicable disease and diabetes being a non-communicable disease. And we should pay attention to the fact that over 60% of deaths worldwide, not just from COVID, but in general, are from non-communicable diseases. And yet research and investment for non-communicable diseases is about 2.5%. So there is a disproportionate the way in which we address non-communicable diseases. My colleague Jeff Copeland would argue that non-communicable diseases are actually communicated diseases. So because they do spread very rapidly in ways we don't imagine. A person having diabetes is very highly likely to also, to use the word infect within quotes, infect his friend with diabetes. And so there is strong correlation between friends having diabetes, between spouses having diabetes, and diabetes running in families. So we can't ignore the social transmission of diabetes either. So I just want to make that point. Now, coming to whether there are certain ethnic groups or certain populations that are more vulnerable to the disease, basically on examining the epidemiology of COVID worldwide, there are clearly indications that in the UK, for example, the Afro-Caribbean community or the Asian Indian community seems to, they argue, are at higher risk of developing the disease and also developing its complications. In the US, the data we have suggests that some groups, particularly Native American groups, the Navajo Nation, for example, our African American population, and potentially increasingly Hispanic populations seem to be at very much higher risk of complications from COVID, whether it's serious complications or mortality. So there is a disproportionate representation of COVID mortality and complications in our African American population, in our Native Americans, particularly the Navajo Nation, and increasingly data suggesting also our Hispanic population. Exactly why that is the case, again, just it goes back to it's a similar question to why people with diabetes are at risk. I think it's multiple factors. I mean, firstly, these are also people that have other comorbid conditions in high proportion, such as diabetes, obesity, heart disease, etc., which puts them at risk of COVID complications. And they also, unfortunately, many of them live in areas of the world or in areas within the United States, in counties, etc., where there is higher levels of other social factors, such as poverty, poor access to healthcare, poor social vulnerability factors, etc. So it's a confluence of several factors. It's the coexistence of comorbidities such as other diseases in the individual and in the populations, and also very importantly, certain health inequity factors such as poverty, poorer neighborhoods, poorer access to healthcare, poor access to healthy foods, etc. So it's all of this together. And in fact, very recently, we have launched a new website, a dashboard called COVID-19 Health Equity Dashboard, which basically is providing data for 3,600 odd counties in the United States on two things. Number one, the epidemiology of COVID in those counties. What's the number of new cases? What's the mortality rate from COVID in that county, etc. And also, very importantly, factors such as how much of diabetes is there in the community, how much of hypertension, how much of obesity, and the socioeconomic factors like how much of poverty is there in the community, etc. So I think this makes it a very complex and important question in terms of the interaction between the virus, host factors such as diabetes and hypertension, and community level factors that have driven health inequities for a very long time.
This is so interesting to connect the dots between health and longevity of a person and the social constructs that we operate in, like race and socioeconomics. You know, in the context of America, there's an argument that race is a public health issue. The American Public Health Association says that race is a driving force of the social determinants of health, and that it's a barrier to health equity. And so what we're talking about here really resonates with that. Could you comment a little bit on whether race is a public health issue and how?
Okay, and firstly, I mean, I can comment on the things that I know, and I'll also comment on things that my colleagues have shared with me. In terms of what I know, I mean, clearly there are differences in health outcomes across several diseases, whether it's life expectancy, whether it's outcomes from diseases such as diabetes, outcomes from diseases such as heart disease, cancers, etc. There are ethnic disparities in the US and worldwide, okay, number one. But importantly, when you examine, US is a very heterogeneous and a very large country. So when you look at the United States, say by counties, there are something like over 3,600 counties across the United States. What we know is that the life expectancy gap between the healthiest and the counties and the least healthy counties is something like 22 to 24 years. So some of our counties have life expectancies like an Afghanistan or a Niger. So there are very poor countries within our country. That's number one. And this is also reflected in variations in things like cardiovascular disease mortality. There is something like an 8-fold difference in cardiovascular disease mortality across counties in the United States, and an 8-fold difference in diabetes incidence across counties in the United States. So there is massive geographical variation. And importantly, when you examine that more carefully, the counties that are least healthiest tend to have higher proportions of certain minority groups, higher proportion of poverty, higher proportion of people without access to primary health care, higher proportion of people with poor access to healthy foods, etc. So all of these are very toxic and complex problems that we are dealing with. Whether race per se has a role in health is an important question that we should address. But one thing we know, at least from the unfortunate events that have surfaced in the last couple of weeks, is that race and racism clearly are important factors. And I was reading a survey this morning which suggests that 74% of Americans believe that what happened with George Floyd actually reflects underlying racial prejudices and underlying racism. So that is something that we have to talk about. It is something that we have to confront, and something that we as a mature society need to try to address in a very constructive manner. It's not a matter of blaming fingers, pointing fingers, but coming up with a way of solving it. And again, my colleagues who have studied the role of racism in health tell me that racism can impact health in several ways. If you're living in circumstances where you're constantly feeling or perceiving prejudice, or suffering its consequences, whether it is by exclusion or by limited access to healthcare or whatever, it can affect a number of things. At a biological level, it might affect stress response, mental health, can affect neurological access, and result in earlier heart attacks, greater propensity for diseases like diabetes, etc. And also, the inadequate access to healthcare becomes an important issue in terms of receiving high quality healthcare or not receiving high quality healthcare. And thirdly, if you're living in neighborhoods that have limited resources, it affects your overall life and well-being. So I think we need to address it not as a simple problem, but a very complex problem requiring multiple levels of intervention. But the starting point is to acknowledge it, talk about it, and also pay attention to all the things that we need to do at the level of policy, at the level of legislation, to try and change this.
So Venkat, this is Nalini. Sorry to interrupt you guys, but you're breaking up quite a lot. So maybe best to stop your video. So could you just, take off your video? Maybe the sound will be better then. Thank you.
Sorry, do you need me to repeat anything or?
No, this is fine, but I just wanted people to hear you.
And thank you, Dr. Venkat, for that response. I think in the public health and in international development fields, we've been connecting the dots between poverty and health, and usually it comes out in the form of topics like nutrition and healthy food and sort of lifestyle of people. And it's so enlightening to hear you talk about the connection between all of these things and infectious disease and pandemic, that oppression and discrimination has an impact on your immune system. And that when it comes time for your immune system to be as strong, it is left compromised. This is very, very enlightening conversation for me. I hope for the audience as well. Let's circle back to diabetes and obesity for a minute. And this question comes from the audience. Do we know if diabetes and obesity are independent risk factors for the severity of COVID-19? Are they important predictors of COVID-19 within individuals of the same race or ethnicity? Or if their impact on severity varies by race or ethnicity?
Yeah, we know from data from several countries, Italy, UK, United States, Spain, and other places, that in general, when you look at the profile of people developing COVID complications, there is a disproportionate representation of people with diabetes, obesity, hypertension, all suggesting that for among those that develop COVID, that these factors, diabetes, hypertension, obesity, does increase the risk of complications. That we seem to know. So I think that's a fairly reasonable statement that we can make. The more difficult question is why that is the case. And I think I alluded to certain factors. Most importantly, hyperglycemia or high glucose levels seems to predict mortality and complications.
Thank you so much. And what can people with diabetes, obesity, and heart disease do to protect themselves from COVID? We talked a little bit about the risk of contracting may not be higher, but when you contract it, the risk of developing more severe forms of the disease or having it affect you in more severe ways is higher. So what can people with non-communicable diseases do in terms of prevention, lifestyle, to protect themselves from communicable diseases like COVID?
Yeah, I think firstly, it's important that they pay a great deal of attention to their own diabetes. Number one, make sure you're taking your medications regularly. Stock up your medications because it might be difficult getting it for a few weeks. So you need to make sure your medication supply is available and you're taking your medications regularly, number one. Very importantly, attend to your healthy lifestyles. I mean, things like regular physical activity. And when you do your physical activity, you might have to change your routines to also comply with social distancing. Make sure you are adhering to a healthy diet, extremely important. And also, if you're stuck at home, there is a tendency to want to eat more. So you need to try to avoid that carefully. Like some people have even joked saying that the best use of a mask is to prevent you from going to the fridge, etc. So I think it's important to do that. Sleeping well, keeping your stress levels low is all important. Avoiding smoking, avoiding alcohol, all of those things are extremely important. So pay attention to your diabetes and also make sure you're checking your blood glucose, frequently. And you might require, if you need adjustments to it, you need to make it. And also take your antihypertensive medications if you're on them. Take your anti-lipid medications if you're on those. So all of that, all the things that you do for diabetes, do it well and do it continuously. And be aware of the fact that should you develop COVID, you would be at higher risk. I think that's number one. And secondly, in terms of preventing COVID itself, I mean, all of the things that we recommend for preventing COVID, clearly, hand hygiene, avoiding touching your face, nose, eyes, very important. Social distancing, we say 6 to 8 feet from, avoiding crowded places, wearing a mask in public places, cleaning your hard surfaces frequently or frequently used surfaces, cleaning your doorknobs, all of that becomes extremely important. And also, if you're going to be socially isolated, make sure you maintain connections with your friends and family, and also keep a list of your phone numbers that you need to call in case you need to call your doctors. All of that is important. And then finally, should you develop symptoms suggestive of COVID or a flu or something similar, such as developing fever, a cough, or muscle pain, and make sure you immediately contact your physician or your nurse to try and find out what this could be. So you need to be a certain level of high alertness. And it might be asymptomatic COVID, or it may not be, it might just be a flu, but regardless, in those situations, it's important to try and quarantine yourself for about 14 days, avoid contact with others. And should the condition get more serious, such as developing difficulty with breathing or persistence of fever, then you definitely need to contact your doctors in time so that you're attended to. And in those kind of situations, it's possible that glucose levels control can go out of sync, and you might require also, adjustment of medications, might need to alter insulin doses. So basically remain vigilant, do everything that you need to do that everybody does to avoid COVID. Pay a great deal of attention to your diabetes routines, pay attention to your healthy lifestyles, and be alert to any infection that might be suggestive of COVID.
It's so interesting, doctor's orders to maintain social connections. And I think what you're saying about healthy lifestyles really resonates with Arogya's mission of changing the course of chronic disease. And folks, if you would like any resources on it, please reach out to Arogya World. There are tons of resources on healthy living. I see some really great questions coming through the chat window. Do you think, Dr. Venkat, that environmental exposures are contributing to the risk of becoming infected or the severity of the illness?
Good question. I mean, all I can say is that there have been studies in the past about the connection between environmental pollution and risk of diseases like diabetes, incidence of diabetes, and risk of heart disease. And there are some indications that that might be the case. But I think in the situation of COVID, there's been a very paradoxical thing that has also happened. When most countries of the world, closed down, they did experience a lowering of environmental pollution, whether PM 2.5 or road traffic pollution. There has been a reduction, and my colleagues in India, for example, tell me they have seen less admissions from asthma, potentially less admissions from other conditions, etc. So there might be certain, benefits from reducing pollution. Whether pollution per se increases complications, I don't know. But, I can only speculate, and I don't want to do that.
That's fair. The conversation so far has been focusing on the US context, and I see a question coming from India that your recent editorial on sarcopenia and diabetes was highly enlightening. Could you please elaborate a little bit on it? And also piggybacking on it, the impact in slums like Dharavi and Mumbai and other areas where the population density is very, very high and people are not always able to social distance. Any comments on those two?
Yeah, let me answer the first one first. I think the article you're referring to is the paper that we published in Diabetics. What is important here is over the last several years, looking at the data on the epidemiology of type 2 diabetes across the world, we are beginning to notice that in the majority of the world, the low and middle income countries of the world, or from populations who have grown up in low and middle income countries, there seems to be a relatively high prevalence of type 2 diabetes, even among thin people, among non-obese people. And the question has really been whether these people, the reason that's the case is because they have higher insulin resistance. But the closer we examine the question, we are beginning to get signals or early findings, preliminary findings, suggesting that there might be additional problems, such as poor insulin secretion to start with, maybe undernourished populations, have several other questions and several other issues involved. Number one, their pancreases may have been compromised. They're secreting less insulin to start with because of historical malnutrition or maternal child malnutrition. Secondly, their muscle development may be impaired and therefore they're not able to metabolize glucose. And very importantly, they might have a propensity to hepatic fat deposition, which would also contribute to insulin resistance. So I think the role of sarcopenia here, or it really is that lower muscle mass relative to total body weight, it may be a problem. I think that's, so there might be additional factors contributing to type 2 diabetes in countries like India, Sub-Saharan Africa, China, over and above obesity. So that was that. And your second question, can you repeat it?
The second question was about highly dense populations, especially in areas like Dharavi in Mumbai, and many other parts of India. And the question is about explaining case fatality rate in these highly dense areas.
Yeah, I mean, again, it's a very tough question. I mean, what we know is the density, like, the probability of contracting infection was high in dense environments, particularly when that density, indoor density is high, is clearly the issue. On the other hand, in places like Dharavi and other crowded places, it's a challenge. I think we need to come up with local solutions. I think that is best answered by people in public health, who are dealing with the problems locally. But maybe things like wearing masks, regular hand washing, trying to maintain what distance you can, making sure you disinfect the hard surfaces, make sure you're very careful about transmission through doorknobs and metallic objects, etc. I think all of those might still apply and can reduce. It's a question of whether you can totally eliminate transmission, or can you reduce transmission. So that may be one of those things where the risk of transmission might be higher in high density places, but you can still reduce transmission by following simple procedures. Yeah.
Yeah, and I think maybe it also goes back to some of the earlier things that we discussed. I know in the context of America, we talked about the connection between race and public health, which translates into different contexts in India, where the socioeconomics show up a little bit differently, but underlying point being that our socioeconomics are determinants of health, and poverty has a strong connection with public health as well as individual health. So there are lots of dots we still have to connect between the structures, the societal structures that we live in, the income disparities that people live in, the access to healthy food, access to less stress environments, and pandemics. Dr. Venkat, I would love to ask you a question about kind of on a macro level. Now that we're connecting the dots between what's happening in the US, what's happening in India, and the global pandemic, that the World Health Organization released a study of 120 countries earlier this week and said that 50% or more of people with non-communicable diseases were not accessing proper care for their chronic conditions. And so non-communicable diseases, as we discussed, include diabetes and heart disease, and communicable diseases include COVID. So what do you think is the reason for lack of access to non-communicable disease care? And what would be some of the long-term consequences of not taking care of NCDs?
Yeah, I think this is a very interesting question. And also, there are multiple sides to this question. Firstly, yes, it's true. A lot of people have reported, like the WHO has said, that a lot of people with existing non-communicable diseases are probably not accessing care. This could have multiple reasons. Maybe, number one, in situations of lockdowns, they may not be accessing their doctors. in situations where people are out of employment and not able to afford their diabetes medications or their hypertension medication, they may not be able to use it. All of that is extremely true. But we also know, both here in Atlanta and in Delhi, colleagues in Delhi, that there has been greater attempts towards other ways of connecting with people and connecting healthcare to people, such as digital health delivery and telemedicine. And that, I'm told, is also quite a successful experiment where those that normally don't come to clinics seem to be attending via telemedicine or via mobile healthcare, etc. So it is really suggesting that if you can aggressively improve access to care through low-cost, convenient manner, not needing people to travel an hour each way, you might actually expand healthcare access. So this might be one of the benefits that has come out of what is happening. It might be pointing out to certain ways in which we need to transform our healthcare system from this heavy involvement, needing to travel great distances, to more digital care, mobile-based care, telemedicine. That might be one of the opportunities. On the other hand, there are also some suggestions that certain conditions are going down. I mean, things like clearly road traffic accidents dropped in India during the time of the shutdown. Things like asthma admissions went down during the time of shutdown. So maybe we need to take a big, broad view in terms of what factors are affecting health and healthcare and how do we fix them. Use the COVID experience as lessons that might have a sustainable value in the future, and exactly understand how coming out of COVID we can make the world a better place, even for non-communicable diseases. And I think it really, what the COVID has highlighted are issues like health inequity are important. Things like non-communicable diseases are important. So maybe it's time to start a conversation, just like we have started in terms of racism, starting a conversation for what should we do to control non-communicable diseases through policy and through healthcare access and through behavior change, so that with the next pandemic, hopefully there won't be one, people with diabetes will not be vulnerable to it. People with heart disease will not be vulnerable to it. I think that's where we need to shift our conversation. Have our systems become too skewed? Have we become too, insensitive in how we deliver it? I mean, by asking somebody to travel, 2 hours, once every 2 weeks to a hospital, is that the best way to take care of people with diabetes, or do we need to simplify the system? So I think it raises a number of important transformative questions that we need to start addressing.
And it really resonates with someone like me with international development background, that the solution to a healthcare issue is not only a healthcare solution, it is to take a systems view. Darren Walker from Ford Foundation has said that people who have been vulnerable to poverty, who have been vulnerable to discrimination, are also the people who have been vulnerable to COVID. And I think we're seeing that play out in the US and in India and across the world. So to build back better, we need to look at many of the socioeconomic dynamics along with the healthcare dynamics. So I really appreciate you weaving all those aspects of our society into this conversation. And a segue to that, to take a even broader macro look, communities and healthcare systems that do take care of NCDs, have they fared better at combating COVID? And I know we've talked a little bit about the relationship between non-communicable and communicable diseases, but in terms of public policy and the attention that our institutions pay to non-communicable diseases, what does that look like? And does paying attention to non-communicable disease also make us stronger to withstand communicable diseases?
Again, all we know is when we examine small area data, that communities with low levels of diabetes, low levels of hypertension, low levels of non-communicable diseases seem to also have, so far, the best we know, also have lower levels of COVID and its complications. Whether it's because they've taken care of non-communicable diseases, or is it that those are also communities with people with the kind of advantages and kind of the ability to lower their risks? We don't know. So, but there seems to be an ecological correlation between a community's susceptibility to non-communicable diseases and a community's susceptibility to COVID complications, which is interesting, but exactly what is resulting in that situation, we don't know. So I mean, to say that communities that have addressed non-communicable diseases better have fared better, I think it's early to say. But one thing we know, that communities with high levels of non-communicable diseases also seem to have high level of COVID complications, which means that it is important to address non-communicable diseases one way or another through multiple policy initiatives. And after all, when you think about the health of the world for the next 20 or 30 years, non-communicable diseases are going to be extremely important.
Right.
And so too environmental pollution, so too poverty. So we need to address all these factors if we are talking about better health and better public health.
Absolutely. And there's a great question I see coming through the chat box. Do we know if there's any global initiatives for recovering the drug supply chain for NCDs during lockdown?
Excellent question. And I think we also need to think of this question, bearing in mind that, say, for example, there's a lot of excitement and anticipation that a vaccine for COVID will become available and hopefully soon. Again, it's too early to say that. There are some indications that COVID might be a kind of virus infection, for which a vaccine might be, easily amenable. But again, there are multiple vaccine initiatives underway at the moment. But even if a good vaccine becomes available, first we need to make sure it's efficacious and safe and can be delivered in real life. And then the important question is, do we have the capacity to make the vaccine affordable and the logistics to deliver it to hundreds of millions of people worldwide, so that the people most vulnerable to the disease and its complications are able to get the vaccine? I think so that way, to addressing the pipeline for the vaccine development and its logistics and delivery is as important as the focus on the basic science research for developing the vaccine, which is important, number one. Secondly, in the area of drugs, it's a very good question. I think what this does point out to, whether it's diabetes management or NCD management or COVID management, it's important to come up with drugs that are low cost and affordable. Repurposed drugs is extremely important. So we need to address essential medicines for the world population in a very serious manner. And there are great initiatives here. I mean, we have the example of ART for HIV. We have the example of anti-tuberculous drugs. We have even the example of generics for hypertension, etc. But scaling that up, and similarly too, for the COVID drugs, it's going to be extremely important. Should a drug become available and should it cost $20,000 for a course, it's not going to be affordable for most of the world and also for a lot of Americans. So I think it's important here to bring in the players involved, the development and the manufacturing players involved, who are able to lower the cost of drug production and delivery and test their efficacy. I think that's extremely important.
Yeah, I think there's so many things that we don't know, like you're saying about building back better, that when the vaccine does become available, the current constructs that we live in, both in India, in the US, as well as globally, there's a huge amount of power dynamics between who will have access to the vaccine and who wouldn't. Would it be the wealthy, the powerful, the folks who told us in the first place not to worry about this pandemic, who will have access to it? And then the essential workers, the people who we bang our pots and pans for every night at 7 p.m. in America, the healthcare workers, people who could not afford to social distance in Dharavi or other parts of India. Will we have access to this vaccine? And how do we make the vaccine, but also in general, the healthcare system, more need-based? I think that's a big question out to everybody, not just to Dr. Venkat or myself, but everybody in the audience. I challenge you to think about that and the part that you can play in building back better, a better world. Dr. Venkat, you mentioned earlier in our conversation about the Emory University COVID dashboard that you are launching next week. Very timely. Could you tell us a little bit more about that?
Yeah, we've actually done a soft launch already. I mean, so the basic idea here is basically, it relates to the conversation today, that we have to connect COVID with health inequalities in a powerful way. So this website, which provides data across 3,600 odd counties, is an attempt to do two things. Number one, on the one hand, provide data on COVID epidemiology by county, such as the total number of cases, the total number of deaths, the total number of deaths in a certain period of time, total number of new cases in the last week, etc. So the COVID epidemiology by county, and we'll also be adding other information when they become available, such as testing rates in a county, hospital beds available in the county, etc. So that's one level, the COVID epidemiology. But very importantly, also paying attention to county level other factors, such as what's the level of diabetes, hypertension, etc., obesity in that county, and what's the picture of socioeconomic variables such as poverty, health vulnerability, populations, groups of people or numbers without insurance, etc. So that any person living in the county or a county health official can look at these two and see where the joint vulnerability lies and what needs to be addressed, both to control the COVID epidemic and also to make sure you're able to reach out to the right people. And more importantly, after the pandemic is over, how do you address these underlying determinants? I think that's the dashboard we have developed. The website is covid19.emory.edu. That's covid19.emory.edu. It's accessible. It's currently funded from seed funds from Woodruff Health Sciences, but there is a foundation that is likely to be funding it very soon. And we would be expanding the dashboard. And if people want to check it out and provide feedback, there is an email address to send feedback to. We are looking for active feedback because we want the data to be useful to people, to public health officials, to academics, and to the media, so that it becomes a powerful resource.
Folks, covid19.emory.edu is in the chat window, and we're also happy to share that link back out to everybody in a follow-up email. In addition, I do see a number of questions about where you're asking for direction on protection and prevention, and Arogya has tons of resources on this. We see you, we hear you, and Arogya would be happy to refer you to the resources at hand. Dr. Venkat, could you tell us about this collective initiative that you are leading for a MacArthur grant?
Yeah, thank you for asking me that question. It's an initiative called Destination Zero. It's aimed at potentially, very ambitiously, eliminating the consequences of diabetes and hypertension. That's the aspirational goal. If you think of diabetes and hypertension, something like 425 million people have diabetes worldwide, and more than 1 billion people have hypertension worldwide. So between the two diseases or conditions, you're talking about 1.5 billion people worldwide and growing. And when we examine the data from very well done randomized controlled trials done by several people, including our own group, we find that a lot can be done to substantially prevent these two conditions through many lifestyle many of the lifestyle initiatives and interventions that we have spoken about, such as better diet, physical activity, reducing stress, improving sleep, etc. So that body of evidence is there from efficacy studies and from field studies to show their implementation. And secondly, we have also, over the last 10 years, built a very strong evidence base showing that if you can improve quality of delivery of healthcare and lower the cost of delivery of healthcare through things like mobile apps and through community health workers, the provision of low-cost generic medications, you can substantially reduce the rate of complications of diabetes and the complications of hypertension by almost 50%. So the body of evidence is available to us from studies done across the world and also from our own group here in Atlanta and our partners in India, such as the All India Institute of Medical Sciences, the Madras Diabetes Research Foundation, and the Public Health Foundation of India. So, and then we also have an NIH grant scaling up these interventions in one population in one district in Punjab. So we have solid evidence that this can be done. So our initiative, as part of the MacArthur 100 and change challenge, is to say, why don't we scale this up to 100 districts in India, which would involve 100 million people, to basically take these interventions and deliver it. And we would deliver it through existing primary healthcare structures and through government healthcare structures. So all that we are doing here is for $1 per person, doing the facilitation of the intervention through apps and through community health workers and through provision of guidelines and through monitoring of quality and developing matrices of implementation. So that's the whole idea. So the goal of Destination Zero is to demonstrate in a large country like India, in close to 100 million people, that this can be done. And we believe that if this can be done, this would be a tremendous inspiration to actually manage non-communicable diseases across the world. I think that's what we're excited about. And there's a lot more details about this. If you go to the Emory Global Diabetes Research Center, we have a specific link on Destination Zero. There is a 5-minute video which explains what it is about. And there is a frequently asked question and answers that explains a lot of it. So please visit Destination Zero at Emory Global Diabetes Research Center.
Thank you so much. And I see a question about why diabetes is singled out in this conversation versus asthma or heart disease. And part of the reason we picked this focus is because it's more unexplored. And there is a stronger prevention component to diabetes than some of the other topics. So that's kind of the gap that we were looking to fill with this conversation, or at least get it started. And we do have only a few minutes left. I have one last question for you, Dr. Venkat. I have to ask this. People are pointing out that women-led countries have managed the pandemic much better. What are your thoughts on this?
Yeah, it's a very good question. Again, it's true. When you look at it, countries like New Zealand, Taiwan, Iceland, Norway, Finland, Germany are all led by women, and they have indeed fared better. And and I wish I had an answer as to why that is the case. Is it that these are countries that had progressive outlooks to elect women, and therefore were already had the substrate to manage a disease and the kind of politics and listening to manage a disease like COVID? Or is it something specific about these leaders or about gender that makes it possible? But I think there are some insights here. If you look at the microfinancing initiative, etc., there are data suggesting that when you lend small amounts of money to women, for example, in Bangladesh, they tend to use that money better and do a better job with it than would men. So is there something that make women and women leaders more cooperative, more collaborative, more nurturing, more listening, and able to take on social responsibility with a broader view? Is it possible? Is that the case? Or, it's a very complex question. So rather than making this a gender issue, I would like to try to distill out the qualities of the leaders and the qualities of that environment that leads to successful public health initiatives, and try to inculcate those kinds of ideas across systems, regardless of who's in power. I think that would be important. I think we should also ask the question why some countries are doing so badly. And in this regard, the United States has not fared very well when you look at how, in terms of managing the COVID epidemic.
And it's interesting to think about the leadership at a macro level and how that affects us on a personal level. Because disease really means suffering and shortening of people's lives in many cases. So interesting to have discussed this with you, Dr. Venkat. We've discussed why people with diabetes are more vulnerable to COVID-19, the relationship between non-communicable diseases and communicable diseases, the relationship between race and health, vulnerability, poverty, race as a public health issue, poverty as a public health issue, the role of prevention, gender, just a few nuggets amongst what we have discussed and learned today. On a personal level, this has been an enlightening conversation and one that's gaining ground in public conscience as well. So thank you so much, Dr. Venkat, for sharing your insights and being with us today. Folks, allow me to hand the baton back to Nalini, who will help us close out this session.
Yeah. Thank you, Swati. Thank you, Dr. Venkat. It was really great to have put so many seeds of thought into all our minds. I really appreciate it. We've had so many people call in, and I'm sure we'll continue the dialogue. There's been a number of questions actually that we haven't been able to address. It's a whole series on type 1 diabetes, and including, if right in the beginning, there were a couple of questions. If you control your sugar levels, are diabetics then equal to everybody else in terms of risk for COVID? And one right now that, are people with asthma, not worse off, or heart disease, so we will come back to you, Dr. Venkat, with all these questions, and we will address each one of them. Thank you for the questions. Special shout out to Dr. Rachel Nugent and to Dr. Yagnik for calling in today. We have very important people in this audience, so thank you for calling in. And Katie, thank you. You've just, it was interesting to see people calling in from, different parts. From my side, I just wanted to say that this women topic is something we are very interested in. And in fact, our next 2 webinars will be exploring different aspects of women and COVID. We are thinking of doing one on July 11th on women and COVID, and you will get more information on that. And then another one in August that Gloria Barone, another of our board members, will lead on, again, a whole women in a different decades, American women in different decades who will, comment on the impact COVID has had on their lives. We will stitch all these together, always with bringing you back to NCDs and NCD prevention, because that's our core. It seems very clear to me that, hey, if we live the way we live in COVID times, or we're supposed to live in COVID times, eat the right foods, and boost our immunity, and take care of, some of the cracks and fissures that COVID has exposed, then I think as a society, we will emerge stronger. This entire series of webinars is called Emerge Stronger from COVID. And so we will try, our best every month with webinars like this for, this. So I just wanted to close by saying that at the core of Arogya World's work is prevention of diabetes and other non-communicable diseases through healthy living. So we internalize the fact that the World Health Organization says 80% of heart disease, 80% of diabetes, and 40% of cancers can be prevented with doing 3 things right. You eat right, you exercise, and you avoid tobacco. Really, we don't need a new vaccine. We don't need new technology. We just have to lead healthier lives. And in my generation, we have allowed this NCD crisis and now pandemics like COVID to happen. So we need to learn from this, and we will. You will get more information, but please look us up. We are doing a lot of work on prevention. And again, Venkat and Swati, this was a fascinating talk. Thank you both.
Thank you to everybody for joining.
Yeah, thank you all. Thank you very much. Thank you.
Bye-bye. Thank you.